consultant endocrinologist with a special interest in pregnancy, diabetes, and thyroid management. And she's going to talk today about thyrotoxicosis in pregnancy.
Morning, everyone, and thank you to the course organisers for this opportunity to talk to you today about thyrotoxicosis in pregnancy. So what I'm going to start by doing is by telling you about a case. So I'm going to introduce you to the case SM. So SM is a 42-year-old female. She has a background history of Graves' disease that was diagnosed back in 2010 in Syria. At the time, she had a mild orbitopathy, which actually was mild enough that she didn't require steroid treatment or immunomodulatory agents. She was treated with thionomide therapy, achieved disease control quickly, and treatment was withdrawn after 18 months. And her subsequent investigations all confirmed that she was in disease remission. So fast forward 9 years, she has a plan to move to the UK, and within about a year, she needs to seek urgent healthcare advice. She has just had a positive pregnancy test, and by her date, she is 4 weeks gestation. Over the previous 4 weeks, she's been experiencing a diffuse rash, which has been concerning her. Now, interestingly, at the time, she had minimal symptoms consistent with thyrotoxicosis, but her results certainly confirmed that she was indeed thyrotoxic. She had a fully suppressed TSH, her 3T3 measured 18.0, the upper limit of normal on our assay is 5.9, and her 3T4 measured 29.9. She was seen promptly by one of our endocrinology trainees in the emergency department. TSH receptor antibodies were requested. And my first question to you as the audience is, what would you do? You're faced with this woman who's in early pregnancy and is thyrotoxic. Would you start her on propyl thiouracil 100 milligrams at a total daily dose? Would you commence her on carbimazole 10 milligrams total daily dose? Or would you monitor her? This could be gestational thyrotoxicosis. Wonderful, thank you. All right. 49. Wonderful. All right, so thank you everyone for responding to that. I'm going to first start by thinking about, so just first by approaching gestational thyrotoxicosis and why this could of course be consistent with gestational thyrotoxicosis. So in early pregnancy, the placenta produces HCG. Now that's primarily there to help drive progesterone so that the pregnancy is maintained. But of course, HCG is also a weak agonist for the TSH receptors. And so in turn, that action then leads to an increase in production of thyroid hormone, such that this then has a negative feedback on the pituitary gland, so that TSH secretion is decreased. And actually, as part of a normal physiological response in pregnancy, up to 5% of women who are pregnant can have an undetectable TSH by 11 weeks gestation. And this graph more closely illustrates the changes that we see with thyroid metabolism in pregnancy. And what I particularly want to draw your attention to is this gray line here, which represents changes in HCG. So I hope you can appreciate that by week 10, we're seeing a peak in HCG levels in pregnant women. And this then subsides over the course of the next 10 weeks, such that actually by week 20, levels are much lower. So of course, by definition, gestational thyrotoxicosis, which is related to that increased HCG production, is very much a self-limiting condition. Now, with our case, if we go back to her, we actually know that she's got this background of Graves' disease, so that renders this maybe a bit more likely to actually be a recrudescence of her Graves in early pregnancy rather than gestational diagnosis, because certainly that background does favor that history of thyroid disease in pregnancy and new presentation. And the other factor that perhaps points us a little bit more towards the fact this could be a flare of her thyroid disease is the fact her 3T3 is so substantially elevated. So just from practical terms, when we're sitting in our clinic, we tend to use a cutoff as 10 to define whether or not somebody may or may not have thyroid disease and whether this could be more likely gestational thyrotoxicosis. But our threshold of 10 is our arbitrary cutoff to help define that. Our TSH receptor antibodies are made very readily available to us. They are 3, and that therefore confirms that this is probably a flare in her thyroid disease. So she's commenced on propyl thiouracil at a total daily dose of 100 milligrams daily, and I'll come on to talk to that in a moment. We also provide her with beta blockade. Now, later in pregnancy, there are concerns using beta blockade in that it can increase risk of intrauterine growth restriction or neonatal bradycardia. But certainly in the early stages, it's very reasonable to use this for short-term purposes to help with cardioprotective measures. She's also provided with a steroid cream and Piriton and seen on our unit within a week. Our dermatologist very kindly got rapidly involved, and they thought that this rash was most likely secondary to an allergic component rather than in any way related to her thyroid status. We continued on her PTU and propranolol. So let's just take a moment now to think about our choice of thionamide therapy. So of course, we use two main agents in the UK, carbimazole or propylthiouracil. In non-pregnant populations, carbimazole is known to be associated with a very low risk of agranulocytosis, affecting 0.1 to 0.3% of exposed individuals, and a bit more commonly a rash, affecting up to 1 in 100. And in the context of pregnancy, there's a documented associated risk of birth defects. And this is reported, if you look at the ATA guidelines, which is probably the guidance out there that has amalgamated the evidence most concisely, they report this risk to be about 3 to 4%. And the most common defects observed are choroidal atresia, which is illustrated here. This indicates a blockage of the nasal passage with either soft tissue or bone. Aplasia cutis, as you can see here, is a skin defect affecting the scalp. And finally, omphalocele tend to be one of the more common associations that we observe. And then if we look at propylthiouracil, there is that slightly higher risk that we know of with agranulocytosis. And in the context of pregnancy, there are reported congenital malformations, though certainly the incidence is lower relative to women who are exposed to carbimazole. So here, commonest birth malformations are periauricular sinuses and cysts or hydronephrosis. But it's important for us to remember, of course, that very rare risk of hepatic dysfunction, and also to bear in mind that actually monitoring liver enzymes is not necessarily predictive of this. Now, this is phenomenally rare, as we're all aware, but there have certainly been case reports of mothers requiring liver transplants during pregnancy after PTU was initiated during their pregnancy, and case reports as well of fetal hepatotoxicity as a result of in utero exposure to propylthiouracil. So let's go back to our case. She's on her treatment, she started taking it appropriately, and she very reasonably asks, why should I be taking this? You know, we disclose the risks to her of taking the medication as we should be doing, and she wants to know what the benefits to her of taking the treatment are. So I'm going to start by just taking a quick step back and thinking about the risks for a woman who is actually planning pregnancy. Now, we know that up to 21% of women who have a diagnosis of thyrotoxicosis actually have a disruption in their menstrual cycles in the run-up to this. So, of course, there is a theoretical concern that fertility could be affected, but important for us all to remember that there is a strong evidence base to support the fact that women do still ovulate, even if they are severely thyrotoxic with irregular periods, and important for us all to bear in mind when we're assessing these women. And now looking at risks of pregnancy-related complications, we have very well-known documented risks of high miscarriage rates if women are thyrotoxic, higher risks of preeclampsia, and higher risks of preterm birth. And there's a known association with incidence of maternal congestive cardiac failure if mothers are severely thyrotoxic in pregnancy, and a suggestion that as a consequence of this, maternal admission to ICU is certainly higher. Now we're just going to look at the risk to the baby, and there are two factors that determine fetal risks. The first being maternal hyperthyroxanemia, and the second being the TSH receptor antibodies themselves. So if we take exposure of the fetus to maternal hyperthyroxanemia in the first instance, we know that risks of intrauterine growth restriction are higher. There was a reduction in the absolute birth weight as well observed in these babies. And finally, case reports of babies being born with congestive cardiac failure as a result. The TSH receptor antibodies themselves cross the placenta readily, and as such have a potential to stimulate fetal thyroid production. This is particularly pronounced from the point at which the fetal gland is actually fully mature, and that we think happens at around 18 weeks gestation. So by nature of those antibodies in high titers, if they cross the placenta, there is the risk that the baby itself could have neonatal thyrotoxicosis. And actually, the other risk is that we need to be mindful of the fact that these TSH receptor antibodies can lead to fetal goiter development. So we do recommend ultrasonography, a dedicated fetal medicine scan at 32 to 34 weeks gestation if maternal TSH receptor antibody titers are high. And we can see an example of a goiter here. And the concern from the obstetric perspective here is that this increases the risk of a face presentation for the baby, thereby rendering delivery more challenging. And I just want to highlight those risks for the baby in the immediate aftermath of pregnancy by looking at this case that was published within the last 10 years. So this is the case of a mother who's 22 years old, has an uncomplicated pregnancy. Up until the stage she's about 31 weeks gestation, and she's found to be measuring small for gestational age. She undergoes a scan which detects oligohydramnios. Later on in the pregnancy, there are signs consistent with intrauterine growth restriction, and her delivery is expedited as a result. And her baby is born measuring 1,800 grams. And I hope you can appreciate here the complete absence of subcutaneous fat on this neonate. And if we look more closely in the signs, we can see at the eyes, we can see signs of lid retraction, periorbital edema, and exophthalmos. And with the gift of hindsight and the gift of being able to go back and revisit the mother's history, it transpired that she'd actually lost a substantial amount of weight during her pregnancy. She was diagnosed with thyrotoxic postpartum, as was her infant. Both mother and baby were started on treatment, and both did very well. But important for us to remember what the consequences are of us not controlling thyrotoxicosis in pregnancy. And there are now suggestions and signals, certainly, that actually exposure to in utero maternal hypothyroxanemia could have longer-term effects for the infants. So there are signals that suggest there is an increased risk of seizure disorders, as well as signals that suggest that neurobehavioral disorders could be higher risk in addition. And this study more closely illustrates that. And I'm just going to try and move this here down below if I can. Okay. So this is a meta-analysis that looked at child IQ, autistic traits, and early pregnancy thyroid function. And it basically looked at 3 separate cohorts in Western Europe and looked at data from 9,036 mother-child pairs. So mothers who did not have a single-term pregnancy, had undergone fertility treatment, who had a known thyroid disease were excluded. And what we can see here are the results from the nonverbal IQ. So here we have nonverbal IQ plotted along the y-axis and early pregnancy 3T4 values along the x-axis. And I hope you can appreciate here that actually mothers who had low levels of thyroid function were more likely to deliver babies that went on to have a lower nonverbal IQ point in early childhood. So that's ages 5 to 8. Now, this, of course, is something we've known for some time, but there were no significant associations demonstrated between thyroid function levels at the upper limits of normal, 3T4 values at the upper limits of normal, and nonverbal IQ. But importantly, there was a signal that actually if offspring were exposed to 3T4 values above the 97th percentile, actually there was an increased risk odds ratio of autistic traits, and that equated to 1.9. That same relationship was not observed in mothers with hypothyroidism. So important signals for us to bear in mind when addressing these women. So back to our case. She is started on her propyl thiouryl in May. Her treatment is then reduced. She was initially started on 100 milligrams daily, if you remember. We see her a month later. We find that actually her T4 has very nicely normalized. Her T3 remains just borderline above the upper limit of normal, but we take the decision to reduce her treatment. And within a month, her thyroid function has fully normalized. So by this stage, she's about 12, 14 weeks pregnant. And my next question to everyone is what you would do at this stage. Would you stop her PTU or would you continue it? Thank you. So nice mix of answers, and probably justifies why I take so much longer in my antenatal consultations than anywhere else, actually. So thank you. Wonderful. So thank you for responding to that. Now, like I say, there are no right or wrong answers for this, actually. And the reality is that we ended up continuing her PTU. And the reason we did this was partly because we rationalized that she was actually on a very low dose, but also because we know about this increased risk of autoimmunity in the postpartum period as well. So if you remember, pregnancy is an immunosuppressant state, and we know that there is an increased risk of thyroid autoimmunity in particular, and a study that illustrated very nicely was a Danish prospective study that looked at women in and outside of the context of pregnancy, and they determined that the odds ratio of a woman presenting with de novo Graves' disease within a year of pregnancy was 3.8-fold higher than a woman who hadn't been through a pregnancy, and mean age to presentation postpartum was about 7 to 9 months. But there is also an increased risk of relapse of Graves' disease in women who actually entered their pregnancy in remission. So there was a very nice case control study that looked at about 150 women. And what they determined was that actually if a woman had had a pregnancy, she was more likely to have a relapse of her Graves' disease. 86% of those women experienced that, relative to 56% of women who did not conceive. So by nature of that, we rationalized that actually it was probably safer to keep her on the medication just to help mitigate for that later on. So we continued the propyl thiuracil. She was started on aspirin at 12 weeks gestation as primary preeclampsia prevention. She had to discontinue that within the space of 6 weeks due to gastrointestinal side effects. And fast forward to her 20-week congenital anomaly scan. So unfortunately on this, we detected a high uterine Doppler index, which does herald risks of intrauterine growth restriction or indeed preeclampsia later in the pregnancy. And in addition to that, we found that the baby was showing signs of kyphoscoliosis. So she underwent a fetal MRI in September. Moderate thoracic scoliosis was confirmed, and in order to ensure that the neonate had prompt access to Great Ormond Street, her care was then transferred to UCLH. Later in the pregnancy, there were concerns regarding pregnancy-induced hypertension. A question mark was raised about the possibility of preeclampsia as well, and there were signs compatible with intrauterine growth restriction. Her delivery was brought forward as a result, but she still was delivered at term at 37 plus 2 weeks gestation. She underwent an elective cesarean section, and her baby was born measuring 2 kilos in weight. So certainly a small for gestational age baby when you consider her own height, weight, and ethnicity. This baby required admission to the neonatal care unit for treatment of severe hypoglycemia, respiratory distress syndrome, and neonatal hyperbilirubinemia. In actual fact, there weren't any abnormalities detected with the spine, so that was put to rest. But instead, they did find signs of a ventricular septal defect as well as a penile anomaly. And on the face value, you can see that the baby's 3T4 was elevated, but actually this can be a normal physiological change in the immediate aftermath of delivery. And actually their TSH was 3.9, indicating that elevated T4 was actually not pathological. Both mother and baby were discharged well within a week. There were no concerns regarding the baby's feeding or developmental milestones at the time, and there were plans for cardiology and neurology follow-up. However, age 7 weeks, the baby very sadly had an episode of massive hematemesis. LAS was called out. The baby was found unresponsive, and unfortunately, attempts at resuscitation were unsuccessful. So we had a routine follow-up appointment organized for this woman at 8 weeks gestation. This is something we do for all our women who are in our joint antenatal clinic to track their thyroid function. And of course, this had all happened at a different center, so we weren't aware of the events. But she very, very kindly came into her appointment, even though it was only a week after this had all happened. And she wanted to ask some very pertinent questions. The first was, did the drugs I took cause this? The second was, did the thyrotoxic cause this, thyrotoxicosis cause this? And the third was, could this happen again? So if we just think about that choice of thionomide therapy, well, we do know there are risks of congenital malformations. And actually, in terms of PTU, that was something that was much less reported on. So historically, all of our guidance suggested this should be a first-line agent. And it's really not until this Danish nationwide cohort study was published that we started to see signals that PTU could also cause congenital malformations. So this study looked at over 800,000 pregnant women, 1,700 of whom had been taking thionamide therapy during the course of their pregnancy. And their overall prevalence of birth defects was actually higher compared to previously reported. So birth defects reported in women exposed to PTU were 8.3%, and to carbimazole or metamethasone was 9.1%. Background malformation prevalence in this cohort was 5.4%. And if we take a closer look at that subdivision of those congenital malformations, up here we can see that the carbimazole group is illustrated there, with musculoskeletal malformations forming the highest incidence there. But if we just take a closer look at the PTU, certainly we're not seeing we haven't had any reported cases of musculoskeletal anomalies. There are, of course, a higher risk of probably the most commonly observed congenital malformations are skin defects in the face and neck, or urinary tract defects. And of course, the little boy had a penile anomaly, and there was this indication that he also had a ventricular septal defect. So possibly related, but of course there is that confounding factor. She is 42 years old, and actually we suspected that the whole picture could maybe have fit a bit more with a syndrome that we had not been aware of. And if we just look at our guidance, and I think this is probably the most robust guidance out there. This is guidance published by the American Thyroid Association back in 2017. Now, for de novo grays, they advocate starting PTU in early pregnancy. But what they do say is that actually, if you have a woman who's stable and euthyroid in early pregnancy on low-dose thionamide therapy, you could consider withdrawing it. Now, of course, we weren't in that position. We had somebody who was significantly thyrotoxic, and we were worried about the risks to her pregnancy later on. But I just want to highlight this before I continue talking about the case, and that is this point here, that what ATA recommends, and certainly what quite a few guidelines recommend actually, is that if you cannot withhold treatment, and if somebody is in carbimazole or metamethasone, then you should actually convert to PTU. And this is the reason I want to expand on it, because if we go back to our Danish cohort study that I've just shown you, which was published after those ATA guidelines, actually what they observed is that women who were exposed to both agents within 3 months of delivery actually had a higher risk of congenital malformations than was observed in carbimazole therapy alone. So very important for us to bear in mind. And this isn't the only study that suggests this potential increased risk if we're exposing babies to multiple agents. This is a large cohort study published in Korea back, I think it was about 4 years ago now, which looked at over 2 million births. Their aim again was to look at the incidence of congenital malformations in offspring exposed to in utero thionamide therapy. And they found over 12,000 of those pregnancies were exposed. Relative to the background malformation risk, as we'd expect, there was a higher incidence of congenital malformations in offspring exposed to in utero thionamide therapy. And again, we're seeing a lower prevalence of birth defects in offspring exposed to PTU alone. Their drug of choice in Korea is metamethasone. We can see that odds ratio there is much higher. But then again, we have these signals that actually if you convert from one to the other, you do not fully mitigate that risk. And it's not necessarily increased as it was suggested in the Danish study, but very important for us to bear in mind. And they also looked at dose dependency as well. And what they found was that actually with PTU, there wasn't a dose dependent risk in terms of an increased risk of congenital malformations, but they did observe that with metamethasone use. So women who were taking higher doses at higher levels of thyroid function in early pregnancy certainly had higher risks to their baby. So let's go back and think about her own risks of preeclampsia and intrauterine growth restriction, which of course we were also seeing signs of in her pregnancy. And if you remember from earlier in the talk, I talked to you about how risk of preeclampsia is increased, preterm birth is increased, intrauterine growth restriction is increased as well. Now, of course, her age will be a factor in all of this as well. It will certainly be a risk factor. But if we take a closer look at one of the studies that has given us these odds ratios, actually, and this study very nicely compared 208 thyrotoxic women in pregnancy relative to controls, which consisted of, I think it was 403. Actually, that group was matched for age, and despite being matched for age, those risks were still higher. And they also commented, and they also found that actually if thyroid disease was uncontrolled in early pregnancy, then that risk was even higher still. So yes, there was a confounding factor in what had happened, but actually you have to ask, had we been aware of her thyrotoxicosis, had we managed it more, could we have mitigated for some of what we observed? So the final question, could this happen again? Well, the reality is we don't know the answer to that. Like I say, we suspected there was probably a syndrome at play here. And unfortunately, the samples that were taken weren't sufficient to be able to give us a clear diagnosis. But there is an argument for saying, well, actually, if we think about the next pregnancy, we get your thyroid disease controlled better, we're hopefully reducing some of those risks of preeclampsia, intrauterine growth restriction. We might not mitigate for it fully, but certainly we could try to reduce the severity. And of course, if she enters pregnancy with nicely controlled thyroid disease, then there is the option as well of withholding PTU, which has its own associated risks of congenital malformations. But really the thing we wanted to discuss with her was definitive treatment, because actually in going down the definitive treatment route, we of course mitigate for all of those that I have just mentioned before. We have two options that we can think about here, surgery or radioiodine. Now we need to consider the risks for surgery, and certainly if you look at incidence of reported risks across studies, these are very variable. We've conducted an audit at our own centre, and we do know our risk for Graves thyroidectomies in particular. So one of our juniors, Larissa, kindly audited this for us. She looked at 92 thyroidectomies that were performed for Graves disease over a 5-year period. 11% of those individuals who underwent a thyroidectomy did have a vocal called palsy, but importantly, that was diagnosed on direct visualization. So actually, as per guidance, this was directly visualized and actually not clinically apparent in a lot of those individuals. And very importantly, there was a full resolution in all of them. We had a post-operative incidence of hypocalcemia of 24%, but over 90% of those showed full resolution within a matter of months. Finally, with radioiodine, the caveat here is in a woman who's over the age of 40, this might not be something she wants to consider because, of course, she needs to be avoiding pregnancy for 6 months afterwards. And the reason for that really is just to make sure the thyroid function is stable effectively, because we know that there are risks of maternal hypothyroxanemia to the baby. 90% of individuals are rendered hypothyroid post-radioiodine treatment, and mean time to hypothyroid in our center from a recent audit conducted kindly by one of our radiology registrars suggested that this occurred by 9 weeks post-treatment. But remember, it's not just about the maternal thyroxine, the maternal thyroxinemia that actually impacts on the development of the baby. It's also about the TSH receptor antibodies. So worth us bearing in mind those changes that can occur following treatment. And this nice randomized controls trial, I think, really illustrates those changes very nicely. So this is a RCT that was conducted in Sweden about 15 years ago, and it randomized a total of 150 individuals to either thionomide therapy for 18 months, surgery or radioiodine treatment. And we can see here the change in TSH receptor antibody status following each of those treatment modalities. And of course, if a woman has radioiodine, then particularly if she's planning pregnancy, very important for us to bear in mind that actually there is a risk that TSH receptor antibodies will persist, and if anything, actually increase above the baseline. So that in turn could confer risks for neonatal thyrotoxicosis or indeed fetal growth to development. So back to our case. She actually opted initially to continue with thionomide therapy. She had excellent disease control and she was very happy on her medication. However, almost right on cue, at about 8 months postpartum, she had a recrudescence of her Graves' disease, which actually proved quite challenging to manage, and we had to titrate her PTU quite substantially. So in the end, she opted for a thyroidectomy, and our surgeons very kindly expedited this on the basis of her potential pregnancy plans. And she underwent this back in 2022, and she's currently considering her options in terms of family planning. So I hope that I've been able to summarize the risks associated with thyrotoxicosis in pregnancy, the risks of treating with our thionomide agents, and finally, perhaps making a case for why it could be so important to consider definitive treatment in this group. Thank you so much for your attention.
very much, Rochan. Right, do we have any questions?
Hi, David Scott Coombs from Cardiff. Thank you. That was really interesting and very clear, except it's left me very confused. So as a simple surgeon, we were always taught if a patient is pregnant with Graves, you convert from carbimazole to PTU because PTU doesn't cross the placenta, so you won't induce congenital neonatal hypothyroidism. And clearly that's not the case because you're showing an increased risk of fetal abnormalities. So which is the bigger risk?
That's a really good question. I think the in an ideal world, if a woman wants to continue thionomide therapy and decides against definitive treatment prior to a pregnancy, we just want her on the lowest possible dose, because by doing that, we're mitigating against those risks of neonatal thyroid disorders when they're first born. But we now clearly know, and I don't think that, at the time that was the evidence, right? We had nothing to support the fact that PTU caused congenital malformations. And it's really only been over the last 10, 15 years, I think that evidence is emerging. So I think what I would say is, whatever agent somebody is on, if they turn up pregnant, we keep them on that, we don't change it. And if there is a suggestion that a woman could fall accidentally pregnant, we don't convert from one form to the other either. So I hope that helps address that.
We'll go online for a quick question. Mushtaq, do you want to unmute?
Sorry. Just say Mushtaq.
Oh, Mushtaq, did you want to ask your question?
Yeah, so thank you for that excellent presentation. I just wondered, I know we get told not to use block and replacement primarily because your thionamide will cross the placenta far more readily than the thyroxine. However, I've had a couple of patients with TRAbs of above 100, which never reduced during pregnancy, and was quite concerning. So if you have a patient, the likelihood is that fetus may have thyrotoxicosis. I just wanted to know a couple of things. One is, what do you use to monitor fetal thyrotoxicosis? I use fetal heart rate, but there you might need to use a higher dose thionamide therapy to control the fetal thyrotoxicosis, but then render the mother hypothyroid. And that is the only situation where I can think of a block and replacement. I don't know what the rest of the audience thinks.
Yeah, Mushtaq, that's a really good point. And to be honest, I don't know that there'd be any guidelines for that even. And there are probably cases that might be worth publishing or getting out there just to illustrate that. I mean, I know ATA says that we shouldn't be using block and replace simply because of that risk of exposure to high dose thionamide therapy. But I suppose if you're thinking about starting it later in the pregnancy and you've kind of gotten over that initial that risk of congenital malformations in the first trimester, I completely understand your rationale for using it. Now, the way we monitor neonatal thyrotoxicosis here is, you're right, we look at the fetal heart rate on our growth scans. We also look at growth of the baby as well. And they actually get 3 growth scans in their pregnancy, in addition to a fetal medicine unit scan to look at their thyroid goiter. And then postnatally, we get our pediatricians involved, and we actually sometimes ask them, if we're particularly worried about a woman, to see them before the baby is born so that they can give the mum an overview about what they'll be looking out for, and cord blood is sent for thyroid hormone. So I think that's a really interesting scenario, and I'm not sure I have the answer to that question, actually.
Can I just make one other point? I've asked the question on chat. If a patient is going to have a thyroidectomy, should these operations be done by high volume parathyroid surgeons in order to reduce the risk of post-thyroidectomy hypoparathyroidism?
Well, I think we're very lucky at our centre in that we have exactly that. And I think we have I would say we have low risk of complications relative to national averages, which is wonderful. But I don't know if our surgeons would like to answer that question or... Okay. All right.
I guess the only thing to say is it may be worth the the woman having her thyroidectomy in a centre with her associated gynae and obs support. And obviously, we also have instances where we are operating on people with uncontrolled thyrotoxicosis in pregnancy. And in that situation, it's not really just about the surgical team, it's about the anaesthesia, the obs support, etc. So that's probably something to bear in mind more.
I'm Karim, consultant, culture staff. Excellent talk, really enjoyed. Can I have two questions? The first one, you mentioned about not stopping a PTU during pregnancy to reduce the risk of postpartum thyrotoxicosis. Is there any evidence that stopping or not stopping has an influence on the reactivation rate? And then the second question is, what sort of advice do you give to your women in the postpartum period about continuing PTU or carbimazole if they're not planning to have any children in the near foreseeable future?
Okay, thank you for those questions. From my understanding of the case control studies, which are probably the ones that give us the best indication of risks of thyrotoxicosis in women with established Graves' disease, there isn't any, that nobody's divided that up according to what you've just suggested, where they look at women who have their PTU or carbimazole stopped in pregnancy relative to those who don't. So I think that's a valid point for us to be thinking about. And then in relation to the second point about whether we convert and whether there's any evidence about that, I don't think there is actually. In personal practice, I just tend to keep going with what they're on. And that's partly because I think we're not as good as in addressing contraception as we should be in postnatal periods. I don't think we're as good as we should be in general anyway. And so actually you just never know about unplanned pregnancy. So until I know somebody is actually on something definitive, then I tend to just keep them on what they're on, even if they tell me that they are considering not having any more kids.
Okay, I think, thank you very much, Rochan. That was really fantastic.
A flying start to the day, and thank you for the questions. Let's keep that going. More questions from the back row, please. Always very welcome. Wouldn't it be nice if at this stage we had an experienced thyroid surgeon who really knows what it's like to be operating on adults and on children, and who might ask, you know, are children just small adults? Well, we do. Many of you will know Tom Kurzawinski, a very experienced thyroid surgeon, and we're delighted to have you, Tom, to guide us through this next topic. Thank you.
Lovely. Thank you very much for your kind indication. When the organizers sent me the proposed title of the talk, I smiled, because it brought the memories just about 30 years ago. When I was appointed, I was stopped in the corridor by a very eminent senior colleague who said, Tom, I think you should start operating on children. And I said, but sir, I have no formal training in pediatric surgery. I couldn't call these eminent people by their first name in my first year of appointment. So it was all sir this and sir that. And he said, don't worry, Tom, old boy. Children are just like adults, but tougher. but over the last sort of almost 30 years, I came to a slightly different conclusion. So today, I hope I will be able to show you that a pediatric endocrinology, also very, very small, but it is a separate field. Wow. I'm so sorry. Just so just that. Well, we really should start with a definition of a child, because you know clearly the 3 or 4 year old, like on the slide, you know, that's a child. It looks like a child, thinks like a child, and it's got a spectrum of diseases typical for a child. But you know, some children are even smaller than that, and they, believe it or not, sometimes require surgery. And obviously there's this other spectrum of childhood, which are called teenagers. And if you ask me which one is more difficult to operate on, it depends on the case. And what we have to also remember that they always bring parents with them to the consultation. And there's never just mom and dad, it's usually a few siblings in a pram, they scream and throw the wobble, there's always an uncle who is a retired GP and an auntie who is a nurse, and they have a very strong views as to what should happen. Now, the world turned around about 10, 15 years ago, and there's various guidelines started appearing about children and endocrinology. And the first one was in the UK. It was Helen Spodia's revolutionary guidelines, very not actual anymore, but then it was very quickly followed by Americans, by Swiss, by Dutch, by more guidelines from the UK. So I think that the consensus is settling into the understanding that children's spectrum of endocrine disease are a little bit, at least a little bit different to adults. So I will argue my case with just few various diseases, and probably differentiated thyroid cancer is not a bad disease to start with. This is a slide, don't worry if you can't read, it's essentially whole continents, various countries and so on. But you can see that the incidence of the differentiated thyroid cancer is very different depending on the age. So in the sort of age 0 to 9, it's extremely rare. And interestingly, the incidence in boys and girls is the same. Then as they get older, then are you going to put me in a picture? Okay. Hello. And when they are about 10, 14, you can see that the girls are taking over and the disease is a little bit more common. And obviously, I'm so sorry. And the age of teenage, it's a little bit like an adult spectrum. And obviously a magic word in pediatric medicine is puberty, and everything changed around that time. So if you translate these numbers to our country, you can see that it's about 1% of cancers are in very, very young children, and nothing much very happen until they're teenagers, and then the disease suddenly takes off. So we have about 13 cases of children less than 15, and probably 1, 2, and sometimes no cases of very, very small children around. We're talking differentiated thyroid cancer, not medullary. That's different. So the incidence of thyroid cancer in children is going up. There's very good data from all over the world. We don't quite understand why this is the case, apart from Belarus, Fukushima, and various places like that, which you can see here, that the incidence obviously went dramatically up, and we know why. But there might be an element of scanning. It's a well-known fact to all of us that if you keep scanning thyroids, you're going to find some cancers. And I think it applies to children as well, because I mean, some most recent papers about scanning pediatric thyroid is quite frightening. 2% of children have solid thyroid nodules, and almost half of them cystic nodules. So we're sort of sitting a little bit of a difficult situation which will explode in our faces, because we'll have to deal with, once it's found, you have to do something about it. So the other difference between the adults and children in the differentiated thyroid cancer is how they present. Of course, most of them present with a nodule in a thyroid, but the nodule in a child is a much more serious affair than in an adult, because the incidence of the cancer in an adult is somewhere, I don't know, 1 to 5% or 2% and so on. But in children, it's somewhere between 20 to 40. So if you have a nodule in a child, in a thyroid, regardless the age, you're not going to sit on it. You're going to do something to find out what it is. Many children present with lymph node metastasis. In my series, about 1/3 of the patients presented with big lymph nodes. Children present with very advanced diseases, a very advanced disease. This is a girl, a teenager, who presented with a papillary thyroid cancer. You can clearly see that neck is not right. And this is all papillary thyroid cancer with multiple bilateral neck metastasis. Children also present much more often with metastasis. About 10 to 20% of children at presentations will have lung metastasis, but you can see that they present with a metastasis, but on the second post on the second radioactive iodine, they very often disappear. And this is some sort of mystery here, because they present with very advanced disease locally. They have metastasis to the lymph nodes. They have lung metastasis, but their survival care is like that. It's phenomenal. You know, hardly ever a child dies of the differentiated thyroid cancer. There are sometimes decades in this country when no child dies of it. Of course, there are occasional cases when it happens. So there's some different biology, because the treatment we have for these children is exactly the same, but the prognosis is much better. I alluded that there are more and more guidelines about endocrine diseases in children, and we have just published a guidelines 2 years ago on a differentiated thyroid cancer. Came up with 58 recommendations. Took us 4 years to write this. So don't worry, I'm not going to take you through all the recommendations, but just a thought that I like the recommendation number 1, when it said that these children should be treated in an environment which has all necessary investigations and treatment. But it's not good enough to have a phenomenal surgeon who can do everything. It's not good enough to have the best radiologist in the world or a pediatric endocrinologist who is interested in thyroid cancer. You have to have all of that and much more in one place. And we hinted in the recommendation number 2 that there is a possible solution to it, because oncologists already organized themselves a little bit into adult and young adults cancer centers. And there are few of them in the country. And linking pediatric endocrine surgery to the centers would be a nice and polite way of sort of trying to centralize the services. Recommendation number 8 and 21 is more how the MDT should be organized, and it suggests that it shouldn't be oncological pediatric MDT, because most of the people in the room know nothing about the thyroid. It should be all adult and children thyroid MDT, because that is a combination of expertise in the room which is necessary. And I like the last one, that it should be all age thyroid surgeon leading it also. That's quite obvious who wrote that one. But I hate the recommendation number 20, and I fought tooth and nail to eliminate that magic number of high volume surgeon, the 30 cervical. I mean, this is just beyond me how this number gets through every single guidelines. You know, 30 is not a lot. I would say that the minimum is 100, but for reasons we can discuss later, this number keeps making it into the guidelines. Not much is known about differentiated thyroid cancer, because, you know, it's a rare disease and there's been nothing really published of value until the group from Marsden and UCL got together and published a paper on oncology over 30 years. So if you're interested, please read it. It's a good document of what's been happening in the UK for the last 20 years. And then we wrote a paper, just looked at our expertise or our series and we drew many different conclusions, of which one is that there are still a lot of children who the triggering point of the diagnosis of a thyroid cancer is an excisional biopsy of the lymph nodes. Now, that is really unnecessary, because this diagnosis can be easily made any other way. So what another message was, and I will keep sort of slightly coming back to it, that who should be doing it? And, you know, if you look at our guidelines recommendation, we're not doing very well, because we contributed 30 children. There were other centers who contributed 5 or 4 children. But look at the last number. There were 24 centers who sent us 1 child for radioactive iodine over a period of 15 years. So a lot of that surgery is done in a hospital which really shouldn't be doing. Now, change a little bit of subject. We're moving from the DTC to some different type of thyroid cancer. We live in an era of precision medicine. And I don't have to tell you what the precision medicine is, but I looked it up in the Oxford English dictionary, which I like when I get, I look into that book when I get stressed. It distresses me. So well, there are certain certainties in it. So, and actually precision medicine is in it, you know, so it made it there. And you know how they sort of almost always quote as to where this appeared first in print. So it wasn't Nature or Lancet or New England Journal of Medicine. It was the Los Angeles County Medical Association physician, and it was in 1992. So well done, LA physician. The word has been trending you, sort of following you all those years. So we're moving now to rat and medullary thyroid cancer, which is another thyroid disease in children, which is worth looking at. So it's also a very good example how the precision medicine's been climbing steadily up. And it all started with the description, which was known as Sippel syndrome at the time. Then we found calcitonin. Then it never stops me smiling that actually the RET mutation was found in papillary thyroid cancer, not in medullary. Took another 3 years to link it to the medullary. And then obviously development of inhibitors and the guidelines. And we now have a disease which is treated with enormous input from science and understanding molecular mechanism of the disease. And some of you came to our symposium, which we organized in 2019 at CRIC, because at CRIC we've got 5 scientists very interested in RET. I didn't know, but I found out. And we just ran a RET at 30 symposium at your meeting in Glasgow, because it's 30 years since the discovery of them. We had some fantastic presentations, and they will be available online. I recommend Louise Mulligan, who was first author on the paper on RET, and Bruce Pounder, who was head of the lab. They're fantastic presentations. Now, the surgical precision didn't make it into Oxford English Dictionary. There's apparently no such thing. So I did a little bit of an editorial task for them, that if they want to put it in the future, one of the first was in a paper called Globe and Mail. And it says there was a surgical precision about his work that bordered on obsessive. I like bordered on obsessive. Well, it's obviously used in Daily Mail, in a sort of more popular sort of culture, sport type of an environment, but this is my favorite. At the end of all, that they must still be capable of functioning faultlessly and hitting their targets with surgical precision, because life depends on it. Well, it's a good description of the life of the NHS surgeon, isn't it? And well done, Sunday Times. So medullary thyroid in children, you know, exclusively at the background of the MEN, never seen a sporadic case in my life. The children are born with relatively normal thyroids, but depending on the type of the mutations, this progresses from normal C cells to C cell hyperplasia. And that can happen within days of weeks in mutations of high risk, that's in 918. Or it can happen slower in 634s and very, very slow in other low risk mutations. But inevitably it happens that they develop C cell hyperplasia. That progresses to medullary cancers and the metastatic cancer, and obviously we want to avoid this. So there is this concept of prophylactic thyroidectomy. Depending on the type of the mutations and age of the child, we perform surgery. We take the thyroids before they get cancer. Again, it was a little bit unknown as to what's been happening in the UK. So I put together a group of extremely committed endocrinologists, mainly pediatric endocrinologists, who allowed me to put together a data between 1995 to 2015. And we sort of looked at the children operated during this time, and we compared them to the guidelines from 2009, not 2015, because most of the children were operated in that time. So if you just, the guidelines are specific when the test should be done and when to do surgery and what type of surgery to do. So we looked at it. So we stratified it according to various risk factors, but I want you to look just at the column all for the simplicity of it. So about half of the children had a genetic test at the recommended time. Now, this is not non-compliance because some of these children were treated before the guidelines were available. I'm just saying that if the child is operated later than recommended, that's what happens. So what happened that in children who had genetic test late, the 76% of them had above normal calcitonin, and half of them had a cancer. Admittedly, very small cancers, but they were already cancers. And the interesting observation is that once you've done the test, the operation happens fairly soon. So it is the genetic testing which is a trigger, and most of the children had an operation within a year. So obviously operation is linked to the testing, so not surprisingly about half of the children have the operation too late, and then they had calcitonin which was elevated, and they also had cancers. So if you look at it into various other statistical ways, is that it looked that in this period we're sort of operating on children a little bit too late, and about 3/4 of the children had an elevated calcitonin, and about 1/3 had an MTC at the time of surgery. And obviously prophylactic means you want to take it out before there is a cancer, because medullary thyroid cancer is a very bad beast. You know, it can metastasize from 1 millimeter. But it's not only timing, it's a choice of strategy. So they recommend certain types of operation in certain situations. And you can see that 68% of children had a total thyroidectomy and 32% had a lymphadenectomy as well. Well, this sounds good, but actually not, because we're talking prophylactic. We're not talking therapeutic surgery here. And look what happened here, that 13% of the children had a normal thyroid, brilliant, good timing. 49 had C-cell hyperplasia, good. 38 had MTC, were small, so hopefully we got away with it. But look at this, only one child had lymph node metastasis, but 30% of children had lymphadenectomies. Does it matter? A good surgeon taking a few lymph nodes here and there, you know, it probably doesn't matter. Well, it does. Because when we looked at the complication rate, what we found out that the complication rate had nothing to do with how small the child was. It only had to do what operation we did. And look at the difference between the complication rate, the children who had just a total thyroidectomy compared to lymphadenectomy, statistically significant, you know, as they say. So it does matter, not just to perform the operation to your best ability, but it does matter to understand the disease and the biology and all these things in the background to make the right decisions. Other complications were very low. It's just hypocalcemia, which was very, very frequent and common. And again, we collected this data covering the period of 22 years, and it's about the same. That, you know, this operation has been randomly done by various surgeons, and if you take into account that it was collected over 22 years, there are surgeons there who performed the one operation in their lifetime. So obviously something needs to be done about it. Well, you can argue a good surgeon is a good surgeon. It doesn't matter how many he does, but actually, this is my final MTC slide, that we obviously follow these children because that's the whole point of the exercise, to see whether prophylactic thyroidectomy actually is effective. So 38% of the children have undetectable calcitonin, 5 points. Within normal range, if you remove the whole, there shouldn't be any calcitonin. But 34% have a fluctuating calcitonin at the upper limit of normal, and only one child had a calcitonin higher than 40. He unfortunately had a recurrence and died. But what is really frightening is that when I look at the data, because we visited the centers for 3 times in this 6 years we collected this data, so the granularity is very good. Some of the children with a normal and elevated calcitonin, that the thyroid removed, and there was no cancer in a thyroid. So if you have a calcitonin fluctuating after surgery for cancer, or there's a lymph node metastasis, which is signaling, the tyrosine kinase signaling is going on and the calcitonin is being produced. But if you remove the thyroid, which didn't have any cancer in it, well, clearly you didn't remove the whole thyroid. So this is just lessons we've learned from this data. So that is almost the end of the talk. I think probably running a little bit over, but I just want to tell you that hyperparathyroidism is also a disease which affects children. I calculated that it's 100 times less common than in adults, taking prevalence and incidence into account. But again, it affects children depending on their age in a different way. It can affect the neonates, and that obviously inevitably is a neonatal severe hyperparathyroidism due to the calcium sensing receptor mutations. And in the mid-grade, it's almost always familial. And then as they get into the teenage years, it gets more and more sporadic. So this is a girl, age 3 months by the time we hear about her. She's not doing very well. She's vomiting, she's dehydrated, she's got hypertonia. Well, her calcium is 6.3. I mean, the highest I have ever seen is 8.6. So, really, and very high PTH. And obviously she's a homozygous for the mutation. So we know what the disease is. So what happens then? Because we know that sometimes these children can respond to the medical treatments, then various treatments are tried. The rehydrations, of course, because the child is very low calcium diet, yeah, but the bones are suffering. And furosemide steroids, nothing. Every time you blast them with calcitonin and biophosphonates, the calcium dips down from 6 to 4. I don't know whether that's a success. But what happens in response to that? The PTH goes up like a hell, and even more bones disappear. And then you say, well, I could have the cinacalcet. But the cinacalcet is allosteric modulator. It needs a normal receptor to latch onto. But the receptor is mutated. 90% of the children with this condition will not respond to cinacalcet. So as the treatments are tried, the demineralization is progressing, and eventually the child breaks her ribs, gets flailed chest, gets to ITU, gets ventilated, and on the scans you can just see the disappearing skeleton. So they transfer to us a happy place, optimistic place, with a lot of very good people who help with this operation. We do surgery. I'm called in because by then I'm world expert on that. I operated on 2 children with that condition already. And they were relatively straightforward operations, but this one wasn't. And we find, you see, everybody expects enlarged parathyroids, but there is no growth. It's just relentless signaling from the mutation. So it takes us ages to find this. And by the time I find third parathyroid, nobody is smiling and everybody looks at me with that sort of controlled hatred. And then we just look for the remaining parathyroid. And if you are a surgeon, you know how it feels. It's just sinking feeling, and And anyway, so we do find it, it's a success. And I just want to say, I mean, the parathyroidectomy seldom saves lives, but there is a disease in children where actually it does. You can see how the whole skeleton, how it all healed, osteoporosis disappeared, and the child survived. Okay, I think I overrun my time a little bit. Thank you very much for your attention.
Okay, I'd like to introduce our next speaker, Helen Doran, who's a consultant endocrine surgeon and general surgery from Manchester, Salford Royal Hospital. and she's going to talk to us about day case thyroidectomy.
Okay. So I was honoured when Professor Palazzo and Meeran asked me to come and talk at this meeting. I've got a long history of wrestling with my thoughts in conjunction with Professor Palazzo about whether or not it's right to do day case thyroid surgery. And when I was putting my thoughts together about what I wanted to talk about, I was really quite reassured when I did a simple day case Google search on day case thyroidectomy. And what was the most important thing to me that came up was about safety considerations. And so what I'm going to do is I'm going to talk through safety considerations as a main premise in the talk about day case thyroidectomy. And I want to make it clear from the outset that we're talking about patients here who are operated on the day of surgery and go home on the day of surgery. So sometimes when you look at papers about day case thyroid surgery, actually we're talking about a 23-hour stay, which is not the same as going home on the day of your operation. And even in some of the American literature in particular, you're not actually discharged home, you're discharged to a place of lower acuity, which may actually be within hospital grounds. So for this talk, it's patients operated on the day of surgery and discharged to their own home on the same day. And a really important factor within this, which I'm going to come back to, is the extent of thyroidectomy. So when we're talking about day case thyroidectomy, are we talking about hemithyroidectomy or are we talking about a total thyroidectomy? Within the safety considerations, the BAETS, so the BAETS is the British Association of Endocrine and Thyroid Surgeons, which is the UK body really representing any surgeon undertaking endocrine procedures. So that's thyroid, parathyroid and adrenal. And they had a consensus, and it's the background to that that I'm going to go through with safety considerations and running alongside that about the guidelines that have come through from a multidisciplinary collaborative group on cervical hematomas and how these should be managed. And then to finish off, I'm just going to touch on how this all interlinks into the NHS elective recovery plan post-COVID and the GERF programme. So there's a whole load of information available about safety considerations for day case thyroidectomy. And some of it is actually really quite unclear when you dig below the surface. We do know that most bleeding occurs within the first 6 hours of surgery, but do we know how significant the bleeding after 6 hours is? I'm not so sure. Total thyroidectomy carries a very increased risk of complications. Obviously, you can get hypocalcemia following a total thyroidectomy, which you won't get following a lobectomy. The total thyroidectomy has a risk of a bilateral nerve injury, again, which you won't get following a unilateral thyroid procedure, unless you're unfortunate and there's an unrecognized pre-existing vocal cord palsy on the contralateral side, but that's quite unlikely. But what we don't know is, intuitively, we think that a total is more likely to bleed. It's got two sides that can bleed from, but is that going to be more clinically significant? And a catastrophic bleed, so that's the patient who bleeds and has an airway obstruction, is that really managed better in a hospital setting than it is elsewhere? You would have thought so. And if you do decide you're going to do your total thyroidectomy as a day case, can you really predict all of those patients who are going to get significant hypocalcemia? And if you do predict it, can you treat it effectively in the community? So back in 2011, the British Association of Endocrine and Thyroid Surgeons had a consensus statement that did not endorse undertaking day case thyroidectomy. Time moved on, and 10 years later, that was quite an uncomfortable position to be in, because lots of procedures were being undertaken as day cases in the surgical community. And also there were various sort of management initiatives going on in hospitals trying to improve costs and reduce costs. And obviously day case would come aligned to this because patients didn't need an overnight stay. So following a large literature review of the new data that had come out since the original consensus in 2011, an analysis of our own British audit data, so UK data, looking at what happened to our patients with postoperative complications and a further membership debate, we actually revised the consensus. And what we said was that day case hemithyroidectomy is now considered an acceptable, safe alternative to an overnight stay for some patients. Individual clinicians should be supported if they endeavour to work alongside their trust development of a clearly defined day case thyroidectomy service. So actually, it wasn't simply, yes, you can do it, or no, you can't. It was that it had to be only in risk stratified and suitable patients within a defined healthcare setting with wraparound safety measures. So the ATS statement didn't say, these are the patients that you can do and you can't do these. What they expected was each individual trust to come up with a risk-based algorithm which allowed for variation, and that variation may be surgical experience, it may be what your community setup was like, it may be what facility that you were doing it in, etc. Each individual patient had to be risk stratified to reduce their risk of bleeding. So if they had risk factors that were going to put at risk of bleeding, then those patients shouldn't be done. And there are well-recognized risk factors, such as patients with Graves' disease, older patients, patients with coexisting comorbidities. And that's particularly important when you think about day case surgery for anybody, is that there are certain criteria that generically patients have to fit under. So they can't be on anticoagulants, they can't be elderly with nobody at home to care for them, etc. So all that was taken as a given. This was looking at patient-specific factors for thyroid bleeding. So there are well-recognised risk factors, but there actually aren't any UK guidelines, although the American Thyroid Association guidelines are very comprehensive and transferable. The key difference being is that the American Thyroid actually endorsed the total thyroidectomy being undertaken as a day case, whereas BATS wasn't endorsing that. The patient needs to be formally consented for the remote possibility of a resultant airway obstruction coming from a catastrophic bleed, and they need to be given written instructions on pre-healthcare management should that actually happen. They need to be within a 30-minute access for healthcare facilities that can deal with the post-operative bleed. And BATS also, at its membership debate, felt that the patients needed to have a minimal stay of 6 hours, and that we didn't feel that completion thyroidectomy was going to be endorsed in the same way as what hemithyroidectomy would be. But that was more based on the concerns about other complications such as post-operative hypocalcemia. So what is low risk, and how safe is it if someone does have a bleed? So this is the first question. What is the incidence of a post-operative thyroid bleed? Yes, please.
So most of the complex 2%.
Mm. So most of you voted for 2%, and a significant number also voted for 0.5. But actually, anybody who put B, C, or D as their answer was right, because there's a range of this even within the national data, but ranges between 0.25 and 2.1%. So low risk and single institutions, they report much lower rates. Some of them even report virtually none at all. And I don't think that's just reporting bias, actually. I think it's as much likely to be that they're not reporting on enough cases, because if your bleed rate is only 1%, you've got to be reporting on at least 100 day cases before you'd expect to get a bleed. These are two very old papers, actually, but they were pivotal in our initial decision at the BATS consensus in 2011 to not endorse thyroid surgery. And that's because they so clearly show about it's the timing and the severity of bleed that makes a difference to outcome. So the first paper was from the Mayo Centre back in 2001, and they looked at patients who were undergoing both thyroid and parathyroid procedures, 8,000 cases, and what they found was a bleed rate of 0.5%. Very low bleed, but they also showed that less than half of those would occur within the first 6 hours. The Poitiers group, they were reported in 2008 on 6,000, and this case control study here, and what they found was that it was a 1% bleed rate, slightly higher as you'd expect, because they were just looking at thyroids. And just over half of those bled within the first 6 hours. The other half didn't. They bled after 6 hours. 1/4, so 25% of those patients that did bleed required an immediate intervention. And it was unclear from this data and from subsequent data as to how these delayed bleeds actually present, they can have a very variable clinical presentation. So we looked at our own audit data. So the BAETS, surgeons upload their cases into there. And one of the variables that we look at is, outcomes that we look at, sorry, is bleeding. And so we looked at our data over a 14-year period, 40,000 cases. And we found, as with in similarities to the other data, that the incidence of a bleed was 1.2%, very low. The incidence of mortality was also very low, 0.1%. But what we did find that was more important was that bleeding is unpredictable. So pseudo R2 values, and statistics isn't my strong point, and I'm afraid I don't really understand them, but essentially they're a measure of how well a variable in a model predicts risk. And we used, or our statistician, I should say, used two different calculations, and they are very, very low. And so what that essentially is saying is that bleeding is random, but the risks that you've identified as being predictors are definite contributions. But the point being that bleeding is random. And so looking a little more closely at the data that we looked at, so within the various variables that are entered into the BATS audit data collection, we looked at the factors that we are known or are thought to be associated with an increased risk of bleeding. And this is for all thyroids, total and hemithyroidectomy. And we clearly showed that being male, an increase in age, undergoing revisional surgery, having a total rather than a hemithyroidectomy increased your risk of bleeding. Having your surgery done by a surgeon who did more than 4 cases per month reduced your risk of bleeding. Surprisingly, being hypothyroid or undergoing a nodal dissection did not change the risk. And so we then looked at the same model for patients undergoing hemithyroidectomy. And in this, we found the risk factors, male age, patient age, and revisional surgery increase risk, whereas surgeons undertaking more than 4 procedures reduce risk. We did confirm, as we'd all suspected, and other data had shown, that the incidence of bleeding is less with a hemithyroidectomy, and the incidence of mortality is also very low. And so when we looked at surgeon numbers compared to outcomes in terms of risk of bleeding, surgeon volume was surgeon volume was a calculation based on how many cases have been put into the registry divided by the number of months that the surgeon had been submitting data for. And we showed that anybody who was undertaking more than 4 procedures a month had a lower risk of bleeding. So the incidence of bleeding is low, and we can have recognized risk factors that are going to predict those patients that will bleed. However, bleeding is unpredictable, so no case is risk-free. And we don't know what the outcomes are of a bleed in the day case setting. And so what is it that we're trying to avoid? So what we're trying to avoid is a patient having a catastrophic bleed. So a patient who bleeds and gets a resultant airway obstruction, which then requires an immediate return to theatre. But it's not just the occurrence of the event, it's also to do with the recognition of it occurring and acting upon it. Because as a patient has a hematoma in the neck, what happens is they get laryngeal edema, and that would make subsequent intubation much more difficult. So the next 3 slides I've stolen from what was a very good talk given by Professor Palazzo to the European Society of Endocrine Surgeons on day case thyroidectomy. And I think he's absolutely encapsulated all my thoughts here, because postoperative bleeding with airway compromise is really the key issue in day case thyroid surgery. But it's a huge elephant in the room because nobody really wants to talk about it, but it's there. So my next question is, what is the risk of a life-threatening bleed at home post-hemithyroidectomy? Is it 2%, 1%, 0.5, 0.25, or 0.1? So this is a risk of a life-threatening bleed. It's not a death, it's the risk of a life-threatening bleed.
Okay, we're voting now. Can you all vote on the point of view?
The vast majority of people are saying that it's 0.1%, and that is correct. And so the calculation from this is, thanks to, again, Professor Palazzo for doing this for me. So basically, there's a 0.8% risk of a bleed following a hemithyroidectomy. We know from the earlier data that that 6% of these will occur outside of the hospital setting. So 50%, sorry, so will occur outside of the hospital setting, and 1 in 4 of those are going to require a bedside urgent intervention. So that's up to 1 in 1,000 patients having a life-threatening bleed at home. I actually think that the numbers are going to be significantly smaller than this, but and I think that because we can now much better risk assess than what we could, and also our techniques generally are better in surgery than when these figures original data came from. But it still shows that there is definitely a risk of some patients having a hemithyroidectomy bleed at home. So part of the guidelines, you may remember as well for the BATS consensus was that we have to give informed consent. But how can we really give informed consent when we don't know what the real risk of preventable hematoma-related death is? So in the era of post-Montgomery, we now have to tell patients about anything that may make them decide that they don't want to go ahead with that procedure. And it's a pretty uncomfortable conversation with patients about the risk of an airway obstruction causing death. But it's so unlikely to happen. It's a remote risk, but it is a risk. And certainly if there's a slightly increased risk by a patient being at home rather than being in the hospital overnight, we need to make sure that we've got the setup around that and safe. And one of those conversations may be giving advice to a parent or carer on how to remove the sutures. But also, you've got to remember that deaths still occur in hospital following postoperative bleeding as well. So you're not always safe in a hospital environment. So alongside Bates's deliberations about whether or not we should or shouldn't endorse thyroidectomy, there was actually a national guideline written, which was a collaboration between ENT UK, the British Association of Endocrine and Thyroid Surgeons, the Difficult Airway Society, which put together not only just a set of guidelines about how to manage a postoperative bleed, but also gave a really useful resource pack as well, which could be distributed so that people knew what to do in the event of this occurring. And embedded within this, and probably actually the catalyst to the production of the guidelines, was something called SCOOP, which is a protocol about how to manage a neck bleed. So you can actually see this on YouTube. You just type it in, management of a hematoma after thyroid surgery. Any eagle-eyed members here will see that that's a 16.5-minute video, but actually the bit that you want to see, which is the opening of the neck, is less than 2 minutes. And it can be used as a frontline resource. And the resources that the guidelines show here are on the left, you've got sort of posters that you can put up at the patient bedside or within the nursing trolleys or wherever. It can be easily seen by people who are looking after a patient post-thyroid surgery, which tells you about symptoms and signs to look out for. The resource in the middle is an algorithm about what to do when you think it's happening, and it can be adapted so you can put the telephone numbers of your own anaesthetists in and your own theatres and etc. So you don't want the FY1 turning up following a bleed on the ward and not knowing who to call and what to do. And then on the right-hand side of the screen, you can see the SCOOP, which is the actual opening of the neck. So the SCOOP is skin exposure, cut the muscles, cut the sutures, open the skin, open the muscles, evacuate the hematoma, and then get a pack in so that the patient can be transferred safely to theatre for definitive management. So why is there such a big interest in day case thyroid surgery now? In any healthcare setting, there's got to be some balance between safety and productivity. And we know that more cases are being undertaken as day case procedures. We know that more complex procedures are being undertaken as day case procedures. We have patients undergoing nephrectomies as day cases now. We have comorbid patients undergoing, highly comorbid patients, undergoing sleeve gastrectomies or Roux-en-Y procedures as day cases. So why is it that we can't do, a thyroid or a parathyroid as a day case? Although, as I should have said earlier, parathyroidectomy is undertaken as a day case in many centres, and that's been one of the difficulties about being able to argue against doing thyroidectomy at times, is because lots of hospitals are already offering day case parathyroidectomy. And the British Association of Day Surgery have a directory of procedures, and that number of procedures that are felt to be suitable for day cases is increasing all the time. And that's due to improved anaesthetic technique, improved surgical technique, better enhanced recovery, see preference for day case and recuperating at home rather than in a noisy ward where you're at risk of nosocomial infections, etc. But I think we all have to be honest and say the true reason is due to cost. So what do we know about cost? Well, there's a lot of good American data that shows it's about 30% cheaper to do a thyroidectomy compared to as an outpatient compared to doing it as an inpatient. But costs are not actually the same as charges, and what the American data is reporting what they charge rather than what the true costs are. And actually, if you look at any patient undergoing a surgical pathway, any patient on a surgical pathway, the vast majority of the costs are completely overwhelmed about what happens in theatre and the recovery area. And actually, the only paper that made it into the NHS evidence base about costs was actually looking at endocrine procedures, showed that the efficiencies were actually due to improved turnaround time rather than the fact that the patient did or didn't stay overnight. So in the US, the endorsement towards a general rollout for day case thyroid surgery came from a whole host of studies, but two particularly important ones were one in 2015, which was a national database, and they had matched patients, 16,000, and they showed that results were comparable in terms of outcomes, and that was bleed, mortality, readmissions. There was a large meta-analysis taken 3 years later in systematic review, and that showed that there were actually fewer complications in the day case group, and there was no difference in terms of readmission and re-intervention if you had your procedure done as a day case compared to having it done as an inpatient stay. And here we have the New York State. They published on 7,000 thyroidectomies, and it's at least as safe as an inpatient. But actually, the devil's in the detail, and only 16% of cases were undertaken as ambulatory rather than as inpatients. And these were predominantly hemithyroidectomies rather than total thyroidectomies. There were younger patients, fitter patients, more affluent patients, and they were undertaken by high volume surgeons. And actually, when you look at the New York State itself within localities, actually only 25% of surgeons overall were undertaking the procedures of day cases. And if you did have it done as a day case, you were twice as likely to have it done by a high volume surgeon. And of all the day case procedures being undertaken, they were actually all being undertaken by 7%. Sorry, half of the procedures being undertaken by only 7% of all the surgeons. So what's actually happening in the UK? So we know that there's absolute record weight for patients. They've got unprecedented weights now. And this is really embarrassing for the government and difficult for the government to manage. And they set a target now that no patient should wait longer than 65 weeks by the end of April 2024. And so there are a number of NHS-led initiatives to try and increase the number of procedures that are being done as day cases. And we've now got a whole working group with a national day surgery delivery pack. And there's lots of different strands to this. What we want to do is separate the emergencies and elective, have surgery undertaken in units which are specialised for day case procedures, in modular units, which we've taken learning from the ambulatory emergency care, where you want to treat your patients on trolleys and don't let them get comfortable in bed with teddies all around them to get them out of hospital more quickly, enhanced recovery programs, etc. So I'm sure majority of you in the audience don't need me to tell you what GIRFT is, but it's a national programme which is designed to improve the treatment of care of patients. And it's really by looking at benchmarking, reviewing services, having clinical ambassadors and experts in the field to look at our data, that's everybody's data, and try and find those where we've got good practices and processes and embed that within pathways which can then be sort of rolled out to other units. And they've got a huge data warehouse where they get information from lots of places, but in particular, they get it from hospital episode data. And they use this along with the clinical oversight and governance to try and build up recommendations and pathways for how we should be undertaking the delivery of healthcare, both surgical and also within your own endocrine settings as well. And one of the things that they're looking at particularly is to try and standardize lobectomy pathways as day cases. And there's a few challenges in here. So there's a safety profile in terms of reporting bias. So that's actually very helpful that HES is looking, well, we can look at HES data because it doesn't necessarily rely then on surgeons reporting it. And you can also look at other markers of, so if someone says, oh, I don't get bleeds, but actually they then say that there was a certain number of return to 30s, then you can use those as surrogate markers to actually comprehensively review the data and sort of validate it. But the worry is there may be a bit of a mission creep as well. So it's okay to do a day case hemithyroidectomy, but will that mean that then units will just go on then and do a total thyroidectomy? So this paper was published in the Agha-Jaffar Archive and Surgery. It was led by Mark Lansdowne, but your own Professor Tolley was heavily involved in the data as well. And I think we've talked about this already today in the two earlier talks, is that actually surgeon volume does make a big difference to outcome. And what they showed here, looking at all surgical procedures, and this is HES data, so this is hospital episode data, so it's not BATS data, and it showed that surgeons who were taking larger number of cases, 20 plus per year, had better outcomes. And within the BATS endocrinology GERF recommendations, number 6 is about improving audit. And the reason for this being put in is that if we do want to see a rollout of day case hemithyroidectomies being undertaken, then it needs to be done along with governance. And one of the ways of reducing the risk is to have surgery done by high volume surgeons. At the moment, the BATS is actually only recording about, when you look at HES data overall, the BATS currently only encapsulates about 60% of thyroid cases, about 80% of thyroid cases, and probably only about 40% of adrenal cases. And so we need to collaborate carefully with our ENT colleagues and our urological colleagues as well. So in conclusion, day case thyroidectomy, it is feasible. The word safe requires that there is an acceptance of some risk within that. Most of the risks can be mitigated, but the only way to be able to mitigate that is to have really good governance structures and correct pathways to make sure that in the catastrophic event of a bleed at home, the patient picks up in a facility that can manage that, not into a unit that doesn't know what to do. And so you have to have pathways for advice, review, intervention, readmission, return. They absolutely need to be crystal clear and watertight. So that means actually training your own in-house juniors, your nursing staff, your A&E staff as well, so that people know what to do when patients turn up, with an airway obstruction. And I think as uncomfortable as it is, that we all have to accept that there are financial constraints within the healthcare delivery. We can't ignore the fact that it may be that now some patients do need to be treated in a day case setting.
Helen, thank you very much. So just a quick question to the audience. Who would have their thyroid operated on as a day case? Can we have a show of hands now, please? So you're on the author of the papers.
Can I just make a quick comment on that? We use the word risk. And maybe we mean by that the likelihood.
Yes.
And a gambler will tell you that the risk is a mathematical product of the odds and the stakes. And so if there's a 1% risk of getting hiccups, doesn't matter. If there's a 1% risk of waking up dead, that's a different thing altogether, but they're both called 1%. And it's the stakes that would make me say, I'd rather stay overnight if that's all right with you. Any thoughts on that?
Well, my thoughts on that are that in a hospital setting, you're not actually always safe. I think you've become very much safer now, because I think one of the big things around the guidelines that came out about management of cervical hematomas, it made everybody wake up to the problem. And I think that's where things like the GERF process can really help, because it does actually enforce, because that is one of the things that will be looked at is what is the management pathway for patients undergoing thyroid surgery. So even if it all comes out that all patients have their surgery as inpatients rather than outpatients, then at least we know that the pathways within the hospital are safe. And I think that over time, and surgery is getting better, the incidence that of bleeds and the need for, your neck being opened in the community, etc., are now going to be getting even better because our techniques have got better and our surgical devices have got much better. So I think the risk of bleeding is going down all the time. I think the key component is making sure that people who have to manage that problem when it occurs can manage it and know how to. And it's hard work, as any thyroid surgeon will know. It means having to go and teach every new set that comes through about the risk of airway management and having the right pathways within your own hospital. But that is certainly one of the things that Gert was going to look at. I think that will help massively.
Thank you very much. I think that's a really inspiring talk. Candid, clear, honest, difficult, challenging, with a way forward as well. Really appreciate that. Thank you. Talks are all very well, of course, but in the end, we need to see patients. And we love to have case presentations here, which sharpen up our abstract thoughts to what would you actually do. So thank you very much for bringing a case for us. It's very welcome that you do so. I always say with case presentations, please be kind to the presenter because you're comfortable and they're not. But do ask questions about each of the cases that are presented. That's very welcome too. We begin with recurrent thyrotoxicosis in pregnancy. I think we're well prepared for that case now. Thank you.
Hello, good morning, everyone. I'm Rabia Arfan. I'm another consultant endocrinologist in Basingstoke Hospital. So I'm going to discuss a case of a patient, pregnant lady, with a recurrent thyrotoxicosis of pregnancy. And I think after a wonderful talk in the morning on thyrotoxicosis in pregnancy, it would be very relatable. So 23 years old lady was pregnant who was in early second trimester of her pregnancy in February 2010. And initial symptoms were of hyperthyroidism, including palpitations and tremors. She didn't have any neck pain or swelling. She didn't have any previous thyroid illness or significant past medical history. She was not taking any regular medications and denies having any significant family history either. On examination, she had sinus tachycardia with quite significant rate of 120, mild late lag, but no other associated dysthyroid eye related signs. She did have bilateral tremors to outstretched hands. On palpation, there was mild goiter, but non-tender, and there wasn't any bruit. There was some wrist reflexes, but no myopathy. So she came to endocrine clinic with her thyroid function, and it did show hyperthyroidism with suppressed TSH and significantly raised free T4 of 43 and raised free T3 as well. So what you guys are thinking of diagnosis at this stage with the history examination and her TFTs? All right, so it's quite a significant sort of opinion that majority is favoring the diagnosis of Graves' disease. Okay, so now we are in a better position because our antibody results are back and it came back negative, including TRAB and TPO. So now we have excluded possibility of Graves' disease. So my next question would be, how many of you will give antithyroid treatment at this stage to this pregnant lady? Okay, so majority is in a favor of giving antithyroid treatment. Okay, so I agree with those who will be treating this lady because this is what we did. We started her, and we'll come to that, why we did that. So she's very symptomatic, and of course, her levels are high. So we started her on PTU, good dose of 100 BD, of course, with ongoing monitoring and repeating TFTs. So this lady needed PTU throughout her pregnancy, normally with the Graves and autoimmune disease. We had a chat about it this morning. We tend to wean it down end of pregnancy because they end up having euthyroid results. So they not necessarily need PTU till the end of their pregnancy in Graves, especially. But this lady needed TFTs, PTU for maintaining her TFTs in the normal range. And not just after that, she had a successful outcome, delivered a normal baby, but she continued to use her PTU, although low dose of 50 milligram once a day. She became euthyroid for 3 months postnatally. And afterwards, it was stopped, and then she stayed euthyroid and was discharged back to community. She became pregnant again next year with the same presentation, became hyperthyroid clinically, biochemically, and we did the same thing as before. We started her on PTU, and again, she needed it throughout her pregnancy and 3 months after her gestation. But this time we investigated her more by doing ultrasound thyroid, which didn't pick up any nodules, but showed some picture of thyroiditis. and her ESR was raised above the normal range between 15 and 16. And between her pregnancy, it went back to normal range. Of course, she was pregnant, so we couldn't offer her radioactive iodine for like a diagnostic purpose. She had further pregnancies in 2017 when she was treated with a similar course of management, and she had another pregnancy. So in between her pregnancy, she was discharged back to community. So last year, she became pregnant again, but unfortunately, she was referred to us through advice and guidance, and we suggested to start her PTU as she was clearly thyrotoxic. But there was some delay in starting her in community, and she lost her pregnancy. That was early week of gestation when she had a miscarriage, but we saw her consequently after her miscarriage in endocrine clinic, and we started her on PTU at that time. So we also discussed about definitive therapy, given this is a recurrence of thyrotoxicosis just when she's pregnant with a negative autoimmunity. She was not interested in surgical therapy. She denied it. And she's actively wanting to have babies, and she has got young kids. So radioiodine therapy is not an option for her. So now she's again pregnant with her 5th pregnancy, and she's under a joint endocrine clinic. And we have discussed about preconception for her next pregnancy because she wants more children. So it would be important to keep her euthyroid before actually she becomes pregnant. So overall, with this history, she wasn't Graves, she wasn't toxic nodules, she wasn't GTT. So she was a rare case of thyroiditis induced by her pregnancy and efficiently managed by PTU. Thank you.
Really interesting. Can I just ask you, how can you say it's not Graves?
So her autoantibodies were checked not just during the pregnancy and outside the period of pregnancy, even when she was not on treatment, and it was always normal.
Does anybody recognize or wonder if there might be a phenomenon of TRAB negative Graves' disease? There's a bit of nodding and waving going on in the room. So maybe we think she's got Graves' disease with a negative TRAB.
So in that case, would you not expect it to become thyrotoxic just during her pregnancy and remain euthyroid outside her pregnancy? Even her 3rd pregnancy was like 5-6 years afterwards, and she never had any symptom or any concerns. And soon she became pregnant. She became thyrotoxic, and this is normally what we don't see in Graves. In Graves, there's a relapse after pregnancy rather than during pregnancy. So she behaves slightly different than a typical Graves patient.
Fair comment. Karim.
Sorry. I was just going to say that actually, if you look at the pattern of autoimmunity in pregnancy, there's often a flare in early pregnancy because that's when the T helper cells are getting activated. And then it switches to T helper cells too later on in the pregnancy. So that's why quite commonly we end up seeing flares of autoimmunity early pregnancy, then suppress, and then postpartum. You're absolutely right, we'd see that. And you're right, you were checking and there wasn't anything postpartum. So I get where you're coming from. But I guess I'm just mindful of the fact that 3% of individuals with Graves' disease are actually autoantibody positive, if I remember correctly. And I wonder whether you had the chance, sorry, negative, thank you. I wonder whether you ever had the chance to consider a technetium uptake scan, or if that was tricky because of breastfeeding.
So, I mean, I met her for the first time. I think this is something we would definitely consider after this pregnancy, just to give it a bit of clarity about her diagnosis. But yeah, I mean, certainly we can discuss that what was underlying etiology behind her hyperthyroidism. But again, I have seen many patients with the Graves, but towards the end of their gestation, they're normally essentially euthyroid without treatment, but she didn't behave in that way. So I mean, it's interesting, even if we can argue it's a Graves, it's different than what other Graves would do it in pregnancy.
There was a time when endocrine disease was not understood because a hormone was not recognized. There were many years when people had menstrual disturbance before prolactin was ever known about. Maybe you're invoking a pregnancy-related hormone from the placenta, which drives the TSH receptor to produce thyrotoxicosis, which is not HCG, lasts the whole of the pregnancy and afterwards, again and again, Nothing to do with antibodies and TRAB. I don't know. Hang on to that serum forever. Did you have anything comment to make?
I'm Jan Sedinius from Stockholm, Sweden. Thank you very much for this interesting case. If I remember correctly, she had lid retraction, right?
Sorry?
She had lid retraction, eyelid retraction.
She did, yeah, but that's quite sort of subjective because she was seen at that time, like 10 years ago, by some other clinician. Recently, I've seen her and I have not noticed any eye-related signs.
Okay,
So, yeah.
because eye disease in pregnancy-related thyrotoxicosis should be almost zero.
But maybe the lid retraction is due to sympathetic drive of Muller's muscle pulling the lid back and not an autoantibody thing. That might be a biochemical phenomenon from thyroid hormones.
But also receptor antibody negative graves can have eye disease.
Yes, absolutely. Yes. Nothing is binary here.
I was just suggesting that do TSH receptor mutations, look for them for activating mutations, and they can just show up in pregnancy sometimes, where the HCG, they're more sensitive to HCG stimulation. So you can then just have recurrent thyrotoxicosis during pregnancy. I think that might be worth doing.
All right, thank you.
There's probably a yearning for coffee as well, so we should move on. Thank you very much for an amazing case. So endocrinologists should remember that there are some endocrine organs below the waist. And we're moving a yard south now to something in the pelvis, I think. Is that right?
Okay. Thank you very much to the organisers for the opportunity to present this very interesting case this morning. So my name is Luke Boyle. I'm one of the registrars based on the Imperial rotation, Northwest London. We're currently working over at Guy's and St Thomas's doing an obesity fellowship. So just by way of background then, this is a 63-year-old lady and she has a background of right-sided salpingo-oophorectomy in 2008. She has a breast lump which is under surveillance with serial mammograms. She's prescribed a PPI and she is a lifelong non-smoker. And she presents with a 6-month history of bloating, dysphagia and reflux symptoms some 15 years later following the surgery she had. So she has a referral is made, a 2-week wait referral to gastroenterology. They do an upper GI endoscopy, which shows that she has mild reflux esophagitis only. And then they arrange a CT abdomen and pelvis to further investigate the cause of her symptoms. So she has the CT abdomen and pelvis, and this demonstrates a 2-centimeter nodule medial to the caudate lobe of the liver. Now, if I can just use the cursor to show you what that is here, you can see it marked by the radiologist as well. And then she also has a 1.5 centimeter pleural based nodule at the bottom of the right lung, which you can't see on that image. So she's discussed in the upper GI MDT, and the recommendation is that she have an MRI liver. So she has the MRI liver, and it reveals three different lesions. So first of all, in the bottom left here, you can see there's a 2 by 2 centimeter mass in the medial aspect of segment 1 of the liver. There's a lesion here at the right lung base. And then there's a third lesion, anterior paravertebral region of the thorax, which you can see here. So next she has an FDG PET scan done. So this shows low grade but focal FDG uptake in the paraesophageal lymph node. Let me just try and move this. And in the soft tissue medial to the caudate lobe. But there's no uptake in the right lower lobe pulmonary nodule over the background lung. So all of these are indeterminate. And accordingly, then she goes on to have a dotatate PET. And you can see the images here on the bottom right. So you can see that there is focal uptake in this paraesophageal node. There's low-grade uptake in the medial, in the soft tissue of the liver. And then there's no uptake in the lung lesion either. There's no thyroid uptake. And the radiologist has recommended histological correlation, of course. So she has some endoscopic biopsies done, which show positive immunostaining for TTF1 and thyroglobulin. And as this audience will know, that would be indicative at this stage of metastatic thyroid carcinoma. So at this point, she is referred to the thyroid cancer MDT, and there's two pieces of information that they want to know that I haven't given you so far. So first of all, she's not had any imaging of her neck necessarily by ultrasound yet. So she has a thyroid ultrasound done, and this shows a 9x6 U2 nodule in the left side of the thyroid. You can see that here. It has this spongy form, sort of honeycomb appearance, as classed as a U2. But because the overall clinical context here, concern about malignancy, she undergoes a fine aspiration cytology, and that confirms that this is a benign Thy2 nodule. She's then discussed at the thyroid cancer MDT, and a diagnosis of struma ovarii, papillary thyroid carcinoma is considered. So struma ovarii is a teratoma which is comprised mainly of thyroid tissue, or at least 50% of thyroid tissue. So the recommendation from the MDT is that histology from the previous gynae surgery in 2008 be obtained. So that is obtained from the Princess Royal Hospital from back in 2008. Histology from the right ovary and fallopian tube, and this show that there's a large cystic teratoma, huge big thing, 1.5 kilos, with well-formed thyroid tissue of fetal origin, and this is also shows positivity in immunohistochemistry for thyroglobulin and TTF1. So the concern here is that this lady may have had micrometastases basically from the disease in 2008 that have now manifested some 15 years later. So she has a two-stage surgery. First of all, in November 2022, last year, she has robotic mediastinal lymph node resection done, and then a few weeks later, she has an exploratory laparoscopy and laparoscopic right cross lymph node excision. And here's the operation note from the second surgery. So you can see here, this is a mobile lesion. It's not touching the IVC. There's one feeding vessel, and it is removed by endocatch. So the histopathology from the samples taken during those surgeries is similar to the previous atypical thyroid lesion within the mature teratoma of the right ovary, which is consistent with a diagnosis of metastatic struma ovarii. So you can see the histopathology report on the bottom left, and on the bottom right here, you can see the classical sort of features of papillary thyroid carcinoma. So we've got enlarged nuclei, they're elongated, overlapping, and those are sort of classical features, as I said. So in terms of next steps in her management then, so with all of this information, the MDT, the thyroid cancer MDT, acknowledges that this is a rare presentation, and there's a clear lack of clear management guidance to move forward. So we move to Mentimeter. So what would you suggest we do at this point? So there's 4 possible options. Okay, so she's had debulking surgery. Do we discharge her with reassurance? Do we start surveillance and observe her for a period without treatment? Do we proceed to total thyroidectomy in order to facilitate radioiodine, or do we go for adjuvant chemotherapy? So someone's asked in the chat, why did she have the oophorectomy? I think it was, the notes are a little bit sketchy from back in 2008, but it was documented as a cyst that she had removed. It was a very, very large cyst. I can't remember the exact size of it, but yeah. That's all we had available. Okay, so most people have gone. Yeah, she was, and somebody else flashed up. Yeah, so she was euthyroid at that time. She's been euthyroid, yeah, throughout all of this. Yeah, I haven't shown you the biochemistry. We'll do towards the end. Okay, so most people have gone for the total thyroidectomy to facilitate radioiodine. So that was correct. So I think over 50 people said go for a total thyroidectomy. I don't know if I shared that properly, but to facilitate the radioiodine. Okay, so the outcome of the MDT favored radioiodine treatment, which necessitates total thyroidectomy prior to radioiodine. And actually, the patient was very keen for that herself, having done a little bit of research in the background. So in terms of the management and follow-up since, so she's had a total thyroidectomy in February of this year. She's recovered well. She's been established on levothyroxine. And she has there was no histological evidence of neoplasia on the specimens that were taken during the total thyroidectomy. She then had her radioiodine in May of this year with thyrogen in the 48 hours prior, and blood's done at the time of the radioiodine. You can see here she has an undetectable thyroglobulin, undetectable antithyroglobulin antibody. Her stimulated TSH is 100, and her free T4 is was going to put the reference ranges on here slightly above the normal reference range of 3T4, and that was because she was on a dose of levothyroxine to suppress her TSH during the period between the total thyroidectomy and having the radioiodine. I think that was the day of the radioiodine. So in terms of her post-therapy scan, this shows good uptake within the thyroid remnant with no distant tracer avid metastatic disease. And then finally, a specimen from the right cross metastasis has been sent off for sequencing, which has detected this very rare BRAF variant that's only been reported in the literature once previously, and the clinical significance of that at the moment is unknown. So in conclusion then, really, these are struma ovarii, these are rare. Metastatic disease in struma ovarii is much rarer still, only about 5% of cases. And there is a lack of clear guidance about how to manage these in terms of malignancy. And that's why an MDT approach is absolutely essential. So the key, I suppose the key take-home message here is that total thyroidectomy is needed first in this scenario in order to give the radioiodine to ablate the metastatic remnants that you have elsewhere. So for further reading, as I said earlier, there's a few case reports that you can look up. This one is from a few years ago, and it's a bit more of a review of the literature as well. I thought that was probably the most helpful one. It's in the abstract booklet if you want to have a further read about this. And then, yeah, just want to acknowledge the team, Guy's and St. Thomas's, especially Dr. Carol, who's been most involved with this lady recently, and happy to take any questions.
Can I ask one?
Yeah.
Do you do the imaging at the time of the definitive dose of radioiodine? It might be nice to know whether these things actually take up the iodine. We presume they will, but you could just do a scan at the time of the administration of the 3.7 gigabecquerels to say,
yeah,
where's this stuff gone?
Yes, I don't think she had. I think it was probably a few days later that she had it. Yeah.
Okay, right. So coffee break. We have completely overrun. So next
Because life
session.
is fun.